Hello everyone. Welcome to Enzyme MBBS, where complex medicine becomes simple and exam ready. Okay, without wasting any time, let's get started. Coming to the definition, first write the definition. So it is the volume of air remaining in lungs after normal expiration. How do you calculate it? Functional residual capacity is equal to expiratory reserve volume plus residual volume, that comes out to be 2300 ml. Okay, so this is the definition. While asking the question of functional residual capacity, they ask the definition, they ask how you will measure it, and what is the clinical importance of it. So definitions we completed. Now let's go to the measurement part. So now measurement, since residual volume cannot be measured using directly by spirometry, FRC also cannot be measured using simple spirometry. All the other volumes, most of the volumes we measure by spirometry, but residual volume cannot be measured. Why it cannot be measured? Because see, spirometry measures only the air that moves in and out of the lungs. Okay, if you observe, residual volume is the amount of air that remains in the lungs even after a maximum forced expiration. So since the air never comes out of the lungs, the spirometer has no way to detect or record it. That's why we say we can't measure it using spirometry. So we use some indirect methods here. Okay, so now what are the indirect methods? So here you have to write two methods. One is helium dilution method and one more is body plethysmography. I have given the answer format for both, but before reading into the answer, hear me first. Okay, so first thing is helium dilution method. How you use the helium dilution method? First thing you remember about the helium, that helium is inert. Okay, it is inert, it does not enter the blood, it only stays in the air spaces. Okay, so here what happens is the subject breathes from a spirometer that is filled with a known concentration of helium. After subject rebreathes helium oxygen mixture and equilibrates with the spirometer, the helium concentration in lungs become same as in spirometer. Now I know you didn't understood anything from it, so hear me now. Imagine a situation, you have a balloon. Okay, correlate that balloon with the lungs. Okay, you have a balloon whose volume you don't know how much volume of air you have filled inside that balloon. Okay, so now connect that balloon to a box. Now that box is spirometer. Okay, you have connected that unknown volume of balloon to a box. Now you know the volume of that box, you know the and that box also has the helium, so you know how much concentration of helium is present inside the box and what is the volume of box. The thing you don't know is the volume of air that is present inside the lungs. Now what you will do, you will allow the helium to mix between the box and the balloon. The same thing happens here. So patient, what he does, he starts breathing from a closed circuit. Like the lungs are connected to the spirometer here, right? He is breathing from that spirometer. You know the volume of spirometer, you know how much helium is present inside the spirometer, what is the concentration of that helium. Now when the patient starts breathing from that closed circuit, that helium moves into the lungs and it mixes with the air already present there. Okay, so after sometimes what happens, the equilibration takes place. What is equilibration? Just again, in simple words, saying that spirometer has helium plus oxygen. Now there is high helium concentration, whereas lung just contains the air. It has no helium, right? So helium concentration in spirometer is not equal to its concentration in the lungs. So when he starts breathing, he breathes in and out from the same closed circuit. Helium moves from spirometer to lungs as well as from lungs to spirometer. So this happens again and again. So helium keeps mixing. So after some time, the keyword that we use, that equilibrates. Equilibration is complete mixing. Now the helium is evenly distributed. So helium percentage is same in spirometer as same as in lungs. So this is what that sentence meant. If you correlate this with an analogy, imagine a glass which has a very strong juice and another glass has plain water. Now you keep pouring from one glass to another. Then what happens, after some time both glasses will have same juice concentration. That is equilibration. Okay, so this is what happens. Why this equilibration is important? Because only then you can apply the conservation of mass principle. I definitely know that you would have studied the conservation of mass in your chemistry classes. Right. So a mass can neither be created nor be destroyed. It can be transferred from. It's something like that comes now. So the same thing. So conservation of mass principle you can only apply after the equilibration happens. So here helium amount is constant, only its distribution have been changed. So using that, we use a formula C1V1 is equal to C2 into V1 plus V2. What is V2? V2 is unknown volume in lungs. What is V1? It is the initial volume of helium oxygen mixture. C1 is initial concentration of helium and C2 is helium concentration after equilibrium. And after mathematical calculations, we derive this formula because we need the unknown volume in the lungs, right? So that's how you get the formula. Now you can just like the formula, you can memorize it. The key point here is you have to understand what we are basically doing, right? I hope that analogy helped to understand it. Okay. So next, if this test begins at the end of a normal tidal volume, it is a normal expiration, the volume of air that is remaining in the lungs is functional residual capacity. The one limitation of this method is helium cannot reach poorly ventilated or trapped areas. So what happens? It basically underestimates lung volume in those cases. So for that, we use one more method which is more accurate method, that is body plethysmography. What you do in body plethysmography, it is also known as Boyle's law principle. Again, you would have studied about Boyle's law in the gaseous state chapter of your chemistry, right? So body plethysmography, in this, patient sits inside a airtight box. Okay, he's already sitting inside a airtight box. Now that box contains air around the body. Imagine you are sitting inside a box, so around your body, inside that box, the air is present, right? And your lungs is also containing the air inside the chest, and there is a mouthpiece whose shutter is closed so that no air enters or leaves the lungs. Okay, so now what happens when the person tries to inhale? When he tries to inhale, the chest expands. While chest expanding, the rib cage is moving outward. So what happens? Lung volume is increasing, so pressure inside lung is decreasing. Okay, so air, what happens? Even though air does not leave or enter, the lung volume still increases because pressure inside lung is falling. Now body volume increases because chest expansion makes the whole body slightly bigger. The body occupies more space inside the box. If the body is occupying more space inside the box, the volume of box is said to be decreased, right? The volume of box is decreasing. So the volume of our body is increasing, volume of box is decreasing. Similarly, pressure inside our lungs is decreasing, but the pressure inside the box is increasing. Now you apply the Boyle's law. What it says, P1 V1 is equal to P2 V2, right? You can, like, one you can give for box or for lungs. Of course, you can measure the pressure inside the box, the volume of box, or you can measure the volume of box. It's like, that's how you calculate. The 3 points, one you is missing, use the formula, you calculate it. So this is the most accurate method, and it includes even non-ventilated lung areas. The exception or the limitation of helium, not exception, the limitation of helium dilution method is solved here. So it includes even non-ventilated lung areas, so it can measure the trapped gases also. So that is the two methods used for measuring the body, used to measure the functional residual capacity. Now coming to the clinical importance. First thing, it acts as a reservoir of oxygen. So imagine during expiration or apnea. What is apnea? It is a temporary cessation of breathing. You imagine you stop breathing for a short period of time. Maybe you were like, sometimes we play a breathing challenge or something like that. I don't know if you have played or not. Yeah, but any other reasons, accidental reasons, there is a temporary cessation of breathing. Okay, so at that time, if there is no volume inside the lungs, there will be a large fluctuation in the arterial oxygenation. So during that time, to avoid this functional residual capacity comes into the role. As soon as the expiration, or if there is any apnea, the oxygen in the FRC continues to diffuse into the blood, preventing large fluctuations in arterial oxygenation between breaths. Next, prevention of alveolar collapse. If there is no residual volume present inside the lungs, then the alveolar wall will adhere, it will collapse, right? Then it would be very difficult for the patients to recover. So that is one of the main role. By maintaining a volume of air in the lungs, FRC helps keep alveoli open and reduces work needed for next inspiration. The third point is maintaining stable gas tension in the lungs. So all times enough air is available for gas exchange along the alveolar capillary membrane. It prevents sudden alteration in gas tension due to any brief interruption or respiration. It's almost similar to the first point. The last point is clinical alteration. What do you mean by, like, what is the conclusion if there is increased FRC? If there is increased FRC, it occurs when there is some obstructive lung diseases. There is some obstruction in the airway. In the diseases like emphysema, asthma, COPD. You'll learn about these diseases in your future classes. But yeah, in these conditions, there is increased FRC. Then when you can see the decreased FRC, you can see in the restrictive lung diseases where lung compliance is reduced. What is lung compliance? If you know what is lung compliance, please comment. What is lung compliance? Well, it is actually the measurement. It is actually the measurement. Repeat with me, because lung compliance is a separate 5-mark question. They can be asked you. So it's I can say in a simple word, the definition of lung compliance is it is the change in lung volume produced per unit change in transpulmonary pressure. In simple words, I can say lung compliance is a measure of how easily the lung expand. Okay, so in restrictive lung diseases, this lung compliance is reduced. So it can be seen in diseases like pulmonary fibrosis, pleural effusion, and acute respiratory distress syndrome. Okay, and one more important point that you have to mention here is anesthesia and supine posture. Okay, I mean, even if you don't mention it, will be chalega, but the thing is that if you mention this and the examiner sees it, like you mention it and make a cloud around it so that examiners can look into it, then you'll definitely get those extra marks, because this is a very important point if you're going to become an anesthetist or whatever. It's very important because see, if the anesthesia and supine posture both significantly reduce the FRC, and during surgery most of the patient will be in the supine posture itself and the anesthesia is given, so you can reduce the FRC, which may lead to the atelectasis. What is atelectasis? It is the collapse of alveolar membrane. Then the patient may undergo a lot of distress. So it's important to track this. It's important to monitor the functional residual capacity during the surgery, and all this you'll learn in anesthesia too. But yeah, that is one important point. Mention it at last. Do a cloud, and that will be a very good answer for this question. And yeah, just write with the headings, boxes, with a good handwriting and all that. You'll definitely get a very good marks in this question. So that's all for today's video. If you like this video, please comment and subscribe.